Good afternoon. It's a pleasure to be speaking to you today on a subject that I think is very exciting for podiatry. When I was trained in podiatry, I did not know a lot about the small fiber neuropathy. But fortunately, I was introduced to Dr. Lee Dellon, professor of neurosurgery and plastic surgeon at Johns Hopkins, and I took his course in the surgical solution for diabetic neuropathy. And about 5 years after getting into that whole world of the micro world of nerves, I saw so many patients with small fiber neuropathy that was not treatable with a surgical procedure. And I said to Dr. Dellon, I said, there's so much more to your theory than just large fiber. And that brought me into this concept of small fiber neuropathy. So I started to do reading that I really never read before. And I was fortunate because I ran into a super scientist at Stanford. His name is John Cook. He has a PhD in vascular biology. He's a traditionally trained cardiac practitioner. And he has a favorite molecule that he likes called asymmetric dimethylarginine. I read that article in Circulation Journal in 2004. I texted him and I said, Dr. Cook, I think this molecule may have something to do with Dr. Dellon's theory of nerve compression. He invited me up to Stanford. We tested my patients with his molecule. And I started to think about this disease process. The literature, back when I was speaking to Dr. Cook in 2004 and 5, it really talked about that small fiber neuropathy was a separate and distinct disease over large fiber, which is really the surgical motor dysfunction of peripheral nerves. And they all had a common denominator in my mind, and that was sugar. Any kind of sugar, it doesn't matter if it was fructose or glucose or maltose. But the chemistry of sugar causes a profound change in the nerve. I was starting to see this small fiber neuropathy, not knowing what it really was. Now, we also call it C fiber, and those fibers are the small unmyelinated fibers that go through the skin. You see the patients every day. Some people call it restless legs. Some people call it fibromyalgia. Some people call it small fiber neuropathy, which it should be called. And then we can differentiate. So how do we make that diagnosis? We have a blood test, ADMA, which is short for asymmetric dimethylarginine, which blocks the nitric oxide pathway. And we can also do a epidermal innervation density biopsy, which will show us the number of nerves per square millimeter. And we have a test that will show that outcome if we're losing those small fibers. And that's why it's small fiber neuropathy. So you see that patient every day. She's probably the 75-year-old, maybe an ex-smoker, maybe she just drinks a little alcohol, definitely on the metabolic syndrome trail, not necessarily diabetic by this point, but she has a chief complaint of burning sensation in her feet. You do an exam. She doesn't have a Tinel sign or a provocative sign, but her feet burn. That's the patient I think we should pursue, looking for that small fiber neuropathy, either through the biopsy or a blood test or both, and look at their diet, and you will find that they have these metabolic syndrome that we talked about years ago, which is really syndrome X, and now it's pretty clear cut, this is prediabetes or insulin resistance. Now, the reason I know that sort of history, because I grew up with that history with Dr. Cook at Stanford, because his laboratory was Gerald Raven's laboratory, and he came up with those terms of metabolic syndrome, syndrome X, and the rest of it. So that gal or guy, and they may have, and a lot of them do, a high intake of alcohol, which destroys the C fibers, causes burning. And it's a nutritionally based type of problem. Not only do they have these environmental problems, but they may have medication issues such as metformin, statin drugs. There's a host of drugs that cause this problem leading up to this syndrome. So why do I know some of this stuff that perhaps the average podiatrist doesn't, because I've devoted the last 20 years to this subject. And I have to thank Dr. Dellon for teaching me the surgical application. I read his textbook, and if you're interested in this subject, you should as well. And Dr. Vinnick, who in some regards is the arch enemy of Dr. Dellon in terms of the approach to this problem, and Dr. Cook, who is, I call him in the middle of this field, because Dr. Dellon's approach is totally surgical. Dr. Vinnick's approach is totally medical and whole foods type approach. And Dr. Cook is somewhere in the middle on this issue. So these are the people that helped me come to this conclusion. There were a couple other doctors, such as Dr. Hamlin at Harvard with his laser therapy, and that's probably a subject for another time. But as I said, I'm traditionally trained podiatrist. I had the fortune of meeting Dr. Dellon. I've been a past president of multiple different organizations, and now my practice is devoted to this subject. And in fact, I wrote a book, and it's on Amazon. It got Science Book of the Year in 2015. If you like to read that, I think it outlines this theory quite well. So one of the things I did when I talked to Dr. Dellon, it seemed like small fiber, large fiber, what is it? And how do you classify it? So I put this classification together, which hadn't been done back in 2004. And I looked at the autonomic side of the equation first, then the sensory, and then the motor. And it seems like most diabetic neuropathies do go through this sequence. Not all of them, but they usually do. Intermittent pain and numbing, we call them zingers, but the real medical term is formication with an M, not to be confused with the other word. And then phase 2 is interval pain, increasing numbness and pain, more frequent, perhaps more intense. When you see a patient, when they hit phase 5, then phase 3, you're going to see this patient and probably they're going to be taking medications such as metformin, Lyrica, gabapentin, Cymbalta. There's a whole host of different drugs that work in the brain, and they don't work at the nerve level. That's the sensory, that's the painful phase. And then phase 4, I hear this every day, Dr. Jacoby, I'm getting better with my Lyrica. I say, why is that? And they say, I have less pain. No, they're getting more numbness, and they're losing that painful problem, and they think they're getting better when in fact they are not. Now they have balance problems in phase 5. They've lost all their sensation. They're insensate. They're building up callus pressure points, and eventually they have an ulcer, gangrene, and eventually amputation. So this is what we're trying to avoid. So when you hear those first formications, those little zingers, stingers, that's phase 1. And then as that progression through to gangrene comes about, we really want to intervene with some type of non-surgical until we get to phase 3. So that's what this talk is really about. What do you do before you get to the phase where you have to surgically intervene? And I think you should take Dr. Dellon's course through AENS, which is the association that he formed, and take the training, read his textbooks, because that's a whole other world. So traditional medicine, allopathic, treats the symptoms. The medications that work in the brain to block the neurons from sensing the pain that this problem is producing from the axons in the extremity. In medicine, especially in neurology, they talk about this as a ascending neuropathy. Well, it really is not. It is a sequential compression of the various different tunnels. And Morton's neuroma is a tunnel. I did a paper 15 years ago that 42% of the patients who had Morton's neuroma had prediabetes or diabetes. So that's one of the clarion sounds in the lower extremity. So we need to look at this as a more systemic disease. And we need to take up our intake form to look at all these, I call them itises. When they're younger people, they have migraine headaches. They may have irritable bowel. They may be taking a GERD medication, which breaks down the B vitamins, which causes the nerve supply to lack the B vitamins and a host of other things that we'll talk about. So this is a progressive, systemic, and insidious process. And this is, its grand scheme is called dysautonomia, when you have multiple different autonomic symptoms. So how do we treat it, or how do I treat it now? I like to treat the small fiber neuropathy from the biochemical standpoint of the nitric oxide pathway. Those things are blocking the nitric oxide pathway. And that means we just talked about patent drugs. They don't work for the nerves, they work in the brain. And over-the-counter medications really are not consistent. They're not well absorbed, and they may not be the right strength. That's why I think the methylated version of all the B vitamins, B1, B2, 6, and then photothiamine derivatives, all those things need to be in these formulations to help these patients in the early phase before they get to a surgical problem. So medical foods, and I really just came to this conclusion not that long ago, understanding how powerful these are. It sounds like they're not really medically effective because they're using the word medical food. So think of it this way: you have over-the-counter or vitamins that are not calibrated, and there's no research behind it. Medical food has to have research behind it to make their claims, and it has to have a high standard of manufacturing. That's the difference. So these vitamins, which they really are the medical food, they can be a terrific benefit to your patients, and certain companies have a great revenue stream for you as well. Instead of writing for Lyric and all the rest of them, which just give you complications and don't give you any change in the outcome, I think the medical food is the right scenario. So let's go back to that patient I talked about, and that patient is that burning foot. They may have been on Lyric, they may have been on Cymbalta, etc. And you just say, take this for 30 days. Even patients that don't want to, or you don't want to do a biopsy or do a lot of blood work, I find a lot of these patients just get better without too much of a workup. And it's beneficial to you, and it's beneficial to them. So that's what I like. Do it a 30-day trial, see how they respond. And if they do, they'll be taking this for long term, and they're going to tell you other somatic complaints throughout their body are going to go away as well. Now, I don't proclaim those changes, but I just appreciate that when they come in and tell me how much better they feel. And without saying this only, the diet is essential. And that's what I profess in Sugar Crush. If you're eating a diet high in carbohydrates, which break down to sugars, that's what causes the inflammation. That's what causes the compression of these nerves. That's what causes the burning, the tingling, and eventually the loss of balance and the motor dysfunction and falls. So there's lots of modalities we can use. These are just some of them. And I think this is a great adjunct to your practice. And I want to thank you for your time.
Give a couple of seconds there on the back end, because what we can do is we're still recording now, but what we'll do is we'll trim it. Here, I'm coming back on. I'm using my.
How many minutes was that?
14, almost straight up. Well done.
I didn't even know. That's amazing.
Great. That's great. I let it hang a little bit at the end, because what we can do is we'll trim all this.
Yeah.
And then we can have Chelsea, if she's a moderator, come in on the back end and say, thank you, Dr. Jacoby. And then it just feels a little bit more natural.
Okay.
Right. So that's kind of what we'll do. We'll see what we got at the front end. But I think that was great. I did pick up a couple of slides I think we need. I think it'd be nice to have to go from this medical foods over to another slide that shows supplements versus medical foods, and it walks through that difference that you verbalized. So I can grab that and make that slide, then go back to this slide. So this slide, just to let them see it, pop over for the validation of medical foods, back to this slide to write it down. And then I think the ending was great. How did that feel? Did you feel like you were able to communicate some of those key points?
Oh, yeah. I mean, I could have gone deeper into it. I don't
Yep.
think we need to. If they don't need to be taught. If they're not doing this, I think it would say, wow, this is a whole different world. I never heard of this.
Right.
So,
right.
Here's what he's only trained 300 people. So,
wow.
20,000 podiatrists.
And it's hard for me, obviously, first of all, I've never even had a biology degree or a biology class. Sorry. You describing this is all new to me. So to me, I'm like, oh yeah, this is just how it is. So it's hard for me to put myself in their shoes, not knowing the information, because everything you've walked through after talking to you a few times and reading all the marketing and writing the marketing, I'm like, oh, everybody knows this.
It's interesting, nor did I 20 years ago, because what happened was when you're in medical school, you are forced to digest a tremendous at all.
Right.
And they force feed you the dogma. And that dogma is based on pharmacokinetics and pharmacology. Every itis gets a drug. If it can't fix it with a drug, you cut it out. So it's the itis is, aspirin is a good example. There are 38 derivations of aspirin, Tylenol, all the names, naproxen, ibuprofen, all those things, all the same drug. What do? I mean, that's a whole other lecture that I give. I mean, if you pounded your head against the wall, would you keep taking Advil to make your head feel better? Or would you stop
pounding my head?
But they never tell you that.
Right.
And that's what sugar is. Never, ever tell you that's the causative agent of inflammation.
Yeah.
So, and in the primary doctor field, that's what they're trained to do. Hear the itis and nail them with the drug.
Mm-hmm.
And see them back in a month. And then there'll be a side effect on that. And you should know that side effect. You add another drug, another drug, another drug. I think Medicare age group somewhere around 20 drugs a day. And it fixes nothing. But it sure does make a lot of money.
It does pump money through the system. Well, hearing you say, kind of that, again, context, just while I've got you for the last few minutes, here's what I'd like to do. I'm going to take myself off video again. But while we're recording, I'd love to have this slide up and then you give a 20 to 30 second quick blip, essentially almost like it's commercial. It's like, hey, I'm going to talk through, hey, this is Dr. Rick Jacoby. I've learned from, Harvard, et cetera, right? Just a couple of quick things. And I want to give you the method that I've learned and have used to treat small fiber neuropathy to avoid surgery. And we're going to have this on here. You don't have to reference it. I mean, you can if you want, but it's going to be on there with you in the center. And then we can kind of have that on the landing page as well as like a little blip. Does that work real quick? And then we can kind of double dip on this time.
Yeah, you guide me through that. I'll just, yeah.
All right, great. So all you, I'm off. So, you can do the talking, but I would just, kind of 20 seconds, just real quick blip. Hey, this is Dr. Rick Jacoby, and I'm teaching an e-course on how to treat small fiber neuropathy. I've learned from X, Y, and Z, and I want to take 20 minutes of your time to show you how to avoid your patients getting surgery or whatever that language is.
Yeah. Hi, this is Rick Jacoby. I just want to talk to you about what I've learned in the last 20 years on the subject of neuropathy. I want to thank Dr. Lee Dellon from Johns Hopkins to get me into this field and the surgical approach to this horrible problem. It results on 100,000 amputations a year in the United States. But of all the patients that I see that need surgery, probably 90% of them could be avoided if they stopped eating sugar and use good supplements in their treatment regimes, not covering up the disease with some medication. Now, I learned over the years that the vitamins that you buy over the counter are really not being absorbed. You need a medical food that has research and is manufactured correctly. And try to keep the patient off of patent drugs like Lyrica and those type of drugs that really don't help the nerve itself. So I want to thank Dr. Cook from Stanford, Dr. Hamlin from Harvard, Dr. Filler from UCLA, and that's just a short list of the people that helped me write my book, Sugar Crush.
A few minutes. As soon as I end the session, us. So that's why I've kept it running, because it ends the session. So I'm gonna go back. I'm gonna rewatch and just see. There were a couple of just in the whatever we've been recording now for 22 odd minutes. There were a couple of technology hiccups. So I just want to make sure everything was smooth. It could have been on my Wi-Fi end, and then I'll let you know thumbs up what we got, and I'll even post it so that you can rewatch it, and then we can make the call of, do we want to add those couple of slides, or are we happy with this as a first gen? I think adding the slides for the presentation would be good, but let's see what we get, because again, we can use it as fodder to send out to a small group, like a sample group of, we've got about 1,100 podiatrists in the HNA network. We can send it out to 100, and we can do a focus group follow-up, and then we can tweak from there if we'd like.
That's a good idea. Very good. Yeah, they're liable to say, you didn't tell us anything new, or I don't know a word you said, I never heard of anything. So that's a good survey.
Exactly. And like, what are the 5 things that you got from it? You know what I mean? And then did we get where we wanted to get to? So that's awesome. Thank you for taking the time. I know your schedule's busy, and I know that time is money. So I appreciate you spending the time.
All right.
Talk to you soon.
See you. Bye-bye.